about PCR biosystems?
There's quite a buzz about us. Hop on over to our website to find out more.
So, hello everyone, and welcome to our Pint of Science 2021 event. My name is Joana, and I'm a PhD candidate at King's College London. I'm researching how neuroinflammation and pain are linked in Parkinson's disease, and today I'm going to host this show today with Val. Val, would you like to introduce yourself?
Of course, thanks, Joana. Hi everyone, I'm Val, and I'm also a PhD student at King's College London. I work in the field of digital mental health. And this year, King's College London is organizing an event around pain. And well, being PhD students ourselves, we know a thing or two about pain.
The good kind, of course. And today we brought you two experts in the field of pain to talk about what actually pain is, how do we feel pain, and actually, why do we feel pain?
Yeah, absolutely. We will also talk about the connection between pain and mental health, how it affects us and how it affects society.
And as always, we love to have you, our audience, as part of the show. Actually, you are the whole point of this show. So please leave us a comment, a question, a fun fact, whatever you would like to share with us in our comment section. And we might share some on the screen. But for starting, I would like to do some shout outs. So with who will have with us today here? So hello, Xhoana from Italy, waiting with you here. Great.
Welcome. Who else do we have? We have Juliana, amazing, from Germany, Frankfurt. Well, what better place to come from with your beer? Welcome.
And we have also Daniela from Washington. Val, we're really international. We're based in...
That's amazing. Welcome, Daniela. It's really good to see you. And yeah, this is an absolutely international audience. How amazing. Thank you, everyone, for joining us. I'm sure you cannot wait for the great talks we have lined up for you. But before we get into those, I brought you all a little game to get us all started. So it's called Pain or Pint. And basically, what I will do is I will show you the name on screen, and you have to guess whether it's basically the name of beer, so pint, or pain medication, so pain or pint, okay? Now, I won't give you very much time between question and answer, so just go with your gut, basically. Now, get some pen and paper or pop your responses in the chat, and let's see how many you get right. Are you ready?
Ready, as always. Let's see what we have.
Fantastic. Okay, well, let's go with the first one. It's Temisoreana. So, Joana, what do you think? Pain or pint?
I mean, your pronunciation, Val, tells me that is a pint.
Okay, well, you're going to think it's everything is a pint then, because the pronunciation isn't going away. But you know what? You are right, in this case anyway. It is a Romanian beer. So, I mean, if you needed any other excuses to visit, I mean, now you have one more. Next, we have berry freeze. So what do you think this is, pain or pint?
I mean, this sounds like a really good name for a cider, actually.
Yeah, I guess it would be, but unfortunately, it isn't a delicious cold strawberry flavored cider. It's cream. So next we have gambrinus. So what do you think of gambrinus? Pain or pint?
I think that's a difficult one. I'll say pain.
Gambrinus isn't pain medication, unfortunately. It's also beer. So in this case, it is a Czech lager. And actually, you can see in the label there, Mr. Gambrinus himself. According to Wikipedia, Gambrinus is a legendary icon of beer, brewing, joviality, and joie de vivre. I'm pretty certain he probably enjoyed science as well, so he's a great guy to have along. He seems like a like a cool guy.
Learning today many things already.
Exactly. Next, we have Tecate. So, what do you think of this one?
Okay, Val, this should be a pint.
Well, you seem very sure about that, and it is a pint. Well, it is beer anyway. And I guess if you got this one right, then you have probably been to the paradise that is Mexico. So congratulations to you just for that, really.
I wish, and I hope our audience have.
Absolutely. Next, we have canca. So what do you think of this one?
Sounds very pint, I'll say.
Sounds very pint. Okay, I'm going to use that from now on. It isn't, unfortunately. I mean, it is a liquid that you can put in your mouth, but I wouldn't drink it, really, if I were you. Canca.
Okay,
So, next, we have characol. What do you think this is, pain or pint?
I think you are trying to trick me with your pronunciation, but
Yes.
I'll say it's a pain medication.
You would be correct. Well done, Joana. This one. So it does sound a bit like a Mexican beer, doesn't it? But it isn't. It's bupivacaine. I had to practice that word, by the way. You see, it didn't practice it long enough. Next. So next we have Ichnusa. What do you think of this one?
I mean, this to me sounds really Greek. I'll say it's a beer.
Ichnusa is a beer. It's an Italian beer, but it's not Greek. Interesting. So, I mean, I think there is a Greek aspect of it. I think it is named after the island it comes from, but I'm not 100% sure. So if anyone does know, then just let us know. It would be really cool to learn other things as well. But yeah, I've never heard of this beer, even though I actually lived in Italy for a little while. There you go. Next, we have, and this is the final one, so make sure you get this absolutely right. We have fast freeze naturally cool. So what do you think?
The stress is going up, Val. I haven't got many right, but I think to me that's a really, really, really great name for a pint. Didn't think of that being a pain medication.
Absolutely. I mean, kind of like berry freeze. I think you've fallen into the same trap, Joanna. Unfortunately, fast freeze naturally cool isn't a naturally cool beer that you don't have to put in the fridge for some reason. It is also something to calm your pain, aches, and everything in between. So, I mean, well done for trying. And I think we found a little gap in the market there for cider and cool beer, didn't we?
I think, and yeah, that was great. I think I hope our audience enjoyed it as much as we did. And actually, I'm wondering how our speakers did. I'll ask them 100%.
I know, right? I am wondering that as well. I'm sure they did a little bit better than I would have done, I'm sure. To everyone else, thank you so much for joining on that little game. I'm glad to have you all on board. And yeah, tell us in the comments how many you got right out of 8, I think. In the meantime, Joanna, do you want to introduce our next speaker?
Absolutely.
Well, our first speaker.
Yeah, our first speaker, of course. So our first speaker for today is Dr. Kirsty Bannister. Hello, Kirsty.
Hi, Joana.
How are you? How's your...
I'm very well, thank you. I very much enjoyed your quiz.
How many did you get right? Did you know that berry freeze was a pain medication?
I have to say, of all the ones I got right, that was my most gratifying. And the only reason I got it right was because I linked it to a kind of ice cream headache. And so I guessed pain on that basis alone. So actually, berry freeze was my my most triumphant correct guess.
Okay, that's great. So let me introduce you properly. So Kirsty is a senior lecturer at King's College London. Her research is focusing on understanding the biology of pain, but also how this changes during chronic pain. And today she's going to talk to us about pain and the brain. And if you have any questions for Kirsty, please put them in the comment section. And in the end of her presentation, we're going to ask them. Kirsty, the floor is all yours.
Thank you. Thanks, Joana, Valeria, George, and the organising committee for inviting me along to speak to you today. I'm going to rely on you to let me know if at any point you can't hear me or you can't see my slides. And I'd like to add that it's a real pleasure to be on a panel with Amanda Williams. So with no further ado, let me kick off this Is It Really All in Your Head seminar by talking to you about pain. Pain is relatively easy to talk about since the majority of us have experienced pain at some point in our lifetime. So pain types are broad-reaching, from migraine or toothache to stomach pain or sports-related pain, such as that you might find in your knee or shoulder after a vigorous game of tennis. What you'll notice from these pictures here, where a face is included, is a grimace, and this ties in with the knowledge that we associate pain with a negative experience. However, it's really important to remember that pain can be good. It's one of the animal kingdom's oldest and most vital sensory and emotional experiences, and it really is key to survival. So if we've burned our hand on the stove, pain ensures that we protect the hand so we don't go out gardening without gloves, for example, which could lead to an increased risk of infection. If we've broken our ankle, the pain enforces us to avoid weight bearing, such as the damaged tissue can heal in an appropriate manner. And if we've had a surgical incision, for example, following an appendectomy or cesarean, the associated pain reminds us to limit our movement until that surgical incision has healed. However, of course, pain can also be bad. And while in the normal situation, a paper cut will heal after a few days, or the pain of broken ankle will disappear after 1 or 2 months, some people experience chronic pain, which is to say pain that persists for more than 3 months. And this type of pain has very much outlived its evolutionary advantage. And chronic pain is a global healthcare problem with huge socioeconomic costs when considering that 1 in 5 people worldwide live with it. For anyone who's experienced pain, you would know that it will interfere with your sleep. Okay, so maybe we've had a few sleepless nights because of toothache. But if this continues, it can very quickly lead to anxiety and really not coping in our day-to-day life, which itself can increase the pain further. And worrying for 2/3 of people that live with persistent pain, adequate pain relief is not received. So you might be asking yourself, why can't we treat this chronic pain? And you might relate this to your own experience. A paracetamol reduced my previous toothache. Ibuprofen reduced the pain associated with my headache. Well, for us to answer this question, we'll first of all consider the definition of pain. And the definition of pain was updated by the International Association for the Study of Pain last year as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Interestingly, pain can be described along multiple descriptive axes. 2 of them are shown here. So we have the sensory discriminative axis, which relates to the intensity of a stimulus. It allows us to locate that noxious, painful stimulus. But crucially, we also have an affective motivational axis, which really relates to the unpleasantness of a painful stimulus and the behavioural reaction that it evokes. And the words an individual uses to describe their pain really tells you a lot about the main descriptive axis that is driving their pain. So words such as you see here, sharp, burning, stabbing, will really relate to that sensory discriminative descriptor, whilst words such as excruciating and uncomfortable relate to that emotional processing of the pain experience. So let's take a moment to sit back and think about what this tells us about pain. If all of us right now were to receive a calibrated blow to the knee, not one of us would perceive the pain of that calibrated blow in the same manner. Some of us would rate it much more painful than others. Some may have had a row with a loved one 20 minutes ago, which would make them perceive this pain worse. Some may have just received news of a job promotion, which could make them score the pain less. But some may have had previous issues, including fear, hopelessness, helplessness, etc., which would altogether cause them to perceive and therefore score their pain much more highly. This keynote supplied by IASP alongside their definition of pain beautifully illustrates this point, that pain is a personal experience influenced to varying degrees by biological, psychological, and social factors. I'd like to highlight here an excerpt from The Guardian this weekend that my postdoctoral researcher Tatum Cummins shared with me yesterday, and it was an article about dreams. And the excerpt states, "The question of why we dream has long divided scientists. Dreams' subjective nature and the lack of means of recording them makes it fiendishly difficult to prove why they occur, or even how they differ between individuals." By replacing only a few words here, we can see how well this correlates to pain. So the question of how we sense pain has long divided scientists, and pain's subjective nature and the lack of means of recording it make it fiendishly difficult to prove why it occurs or even how it differs between individuals. The take-home message here being that pain is a subjective experience. In order that we might understand why pain is subjective, we are going to consider the biology of pain. So here is our spinal cord, which functions as a relay center for incoming signals from the periphery that can relate to a noxious status of a stimulus, so a hot or cold burn, that we may need some berry freeze to treat, or a mechanical insult such as a bang to the shin. The spinal cord speaks to the other components of the central nervous system, the brain, in an orderly fashion, such that different brain regions are responsible for processing different aspects of the pain experience. So take, for example, here's our hand, and we've had a burn to the hand or a knock to the hand, and these incoming signals will arrive in the spinal cord and carry that pain message to specific areas of the brain. Certain areas of the brain will allow us to locate the pain. It's my hand. I'll remove my hand from the source of threat or injury and describe its intensity. But that pain message is also carried by parallel pathways to limbic areas of the brain that process emotions. And so the psychological aspects of pain are experienced at the same time as the sensory discriminative. And it's not possible to have one without the other, since both are intrinsically linked. So relating to the title of the talk, having considered the biology of pain and the pain processing pathway, I'd like to ensure that you're all aware that yes, pain is all in your head, but the pathology can be in multiple places, for example, your knee, shoulder, or hand joints. So let's now change the angle slightly to tie the biology of pain to pain treatments. And in order to understand how pain relieving treatments work, or the ways in which we need to improve them, we need to consider the second keynote here supplied by IASP, which states that pain and nociception are different phenomena, and pain cannot be inferred solely from activity in sensory neurons. So nociception is the neural process of encoding impending or actual tissue damage, whilst pain is that subjective experience of actual or impending tissue damage. And as you can see here, nociception is physiologically composed of 4 processes. So if we tie this to that biological pain pathway, we have transduction at the periphery. So if I burn my finger, specific specialized nociceptors in my skin will detect that heat pain, and this will drive a pain signaling process via action potential generation to the dorsal horn of the spinal cord. So this is our transmission of the pain signal, which, as I showed you, is relayed to different brain regions. And then we have modulation, whereby the brain is able to either dampen or facilitate those pain signals in the spinal cord. And finally, we have that perception, that subjective experience of that noxious stimulus. So if we know so well the biology of pain processing pathways and these underlying mechanisms of pain perception, why can't we treat chronic pain effectively? And why don't we treat all pain in the same way if this is the generalized pathway that describes pain processing? So chronic pain treatment. Many of you, I'm sure, if not all of you, will have heard of morphine. Morphine is a gold standard analgesic and one against which all others are compared. So if an individual presents with pain, whether it's acute or chronic, why aren't we simply giving them morphine in order to alleviate that pain? Well, there's 2 problems. The first problem is the opioid crisis, which I'm sure many of you will be aware of. So if we take the status in America, where more people live with chronic pain than diabetes, cancer, and heart disease combined, we know that there's a huge issue in terms of number of opioid-related deaths a day, where almost half of those related deaths are from prescription opioids. If you look at this picture in the bottom left-hand corner of the screen, this shows the lethal dose of pure grade heroin versus the lethal dose of pure grade fentanyl. And so you can quickly understand how an individual who's been using heroin in terms of street use might get themselves an opioid prescribed medication such as fentanyl and take a much larger dose than they mean to and subsequently die. So that's the first problem with throwing opioids at the pain. The second problem is that opioid-based analgesics do not target the underlying molecular mechanism of chronic pain complaints when we think about pain as varied as neuropathy, osteoarthritis, or fibromyalgia. So we can't treat all pain in the same way because the underlying pathology changes according to the disease. So pathology might drive the pain that's perceived by the brain. For example, in the case of osteoarthritis, a joint replacement alleviates the pain in, I believe it's around 65% of individuals. But then if we've had a nerve lesion during an operation, pain might persist after that surgical incision is healed. So we have neuropathic pain, where pain may be caused by prior surgery. And of course, we know that pain can exist in the absence of any prior pathology. For example, fibromyalgia, where pain is perceived, but there's no obvious insult to the periphery. So we can link what we know about common but different pain relief strategies to the pain processing pathway and begin to understand why we need to treat pain differentially according to the underlying pathology and the acute versus chronic status. So if we think of our basic pain processing pathway from periphery to the central nervous system, and we have injured ourselves, our foot, our head, anywhere on our skin, we know that we can use non-steroidal anti-inflammatory drugs which will work at the periphery. So they will act to reduce the amount of this inflammatory soup of the prostaglandins, in terms of there being less pain signals driven into the central nervous system, which means our brain perceives less pain. So examples would be ibuprofen or aspirin. And of course, along these nerves themselves, we can use local anesthetics such as lidocaine, which will impact voltage-gated sodium channels, which means that those action potentials that propagate that pain message along the nerve don't actually function. In central terms, in terms of brainstem and spinal cord mechanisms of action, we know that the anti-migraines and anticonvulsants, which are the frontline drugs for neuropathic pain, the gabapentinoids, will impact and bind to their respective receptors and accessory subunits throughout the central nervous system. So this would, for example, include the triptans and the gabapentinoids. And then, of course, we have our opioid-based medications, morphine, codeine, cocodamol, tramadol, tapentadol, etc., that will bind to opioidergic receptors throughout the central nervous system to alleviate the pain that we feel. Let's end as a hopefully fitting start for Amanda's talk by considering the following. Antidepressants are used to great effect in terms of pain relief, and by ensuring increased availability of the monoamines noradrenaline and serotonin in brain and spinal cord pathways, pain may be inhibited. So drugs that are especially efficacious in this sense would include fluoxetine, amitriptyline, and duloxetine. The question that we researchers need to ask ourselves is, are some people more predisposed to developing mental health issues and chronic pain? Of course, pain generates a negative affective state, which when experienced chronically leads to the development of disabling mental health symptoms. So understanding that emotional processing and pain processing is intrinsically linked is a vital step towards improving the lives of those that live with chronic pain. On that, I'd like to thank you for listening and acknowledge the wonderful people with whom I work in order to understand the biology of pain, where you will see that multiple inputs from multiple disciplines are required in order that we can address the global issue of pain. Thank you.
Thank you, Kirsty. This was brilliant, very clear conversation. I was going to ask something, but I think we have so many comments from like the audience that I would definitely start with them. So what are your questions? So we have Xhoana that she's asking, how much can we interpret from animal studies on pain in clinical human terms?
So the aspect of forward and back translation bench to bedside is a really crucial one when it comes to pain research. We need to infer pain behaviours from animal studies and translate those to what we observe in the clinic. But more crucially, where the most relevant information has come in terms of novel analgesic stuff for pain relief, we need to back translate from the clinic to the preclinical domain. So we can interpret certainly a fair amount in terms of behavioural phenotypes, but if we want to understand the underlying mechanisms that drive a pain state, then we need to go to the animal models where we can dissect on a molecular, anatomical and functional level the very circuits that we are trying to target pharmacotherapeutically in the clinic. So in short, we can't do one without the other. We need the preclinical and clinical aspects, and mostly these do marry quite well. But of course, the translational potential needs to be improved in order that we have improved therapeutic profiles.
Great, thank you. So let's go to another question from the audience. Okay, so Athanasios is asking, how early attachment experiences, secure or insecure, could affect the experience of pain? Such a great question.
So this is a brilliant question, and I feel massively underqualified to answer it. So what I'm going to do is answer it whilst pushing your attention to the amazing researchers who look at the impact of adverse childhood events on pain perception later in life, because we absolutely know that those adverse events have a huge impact on how we perceive pain. Individuals including Rebecca Slater, Mariah Fitzgerald, Melanie Knoll, these are people who really bridge the clinical, psychological and basic science research bridge when it comes to understanding exactly what those childhood traumas, the impact that they have on future pain perception. So certainly an insecure early attachment experience will affect the experience of pain later, for all the reasons I've outlined in terms of pain not just being a sensory mechanism, but also an affective one as well.
Thank you. Then I think we have time for another one or two. I think we have another. So Lucas is asking, are cannabinoids a good alternative to morphine? Right?
This is a really contentious question, and actually just recently IAS produced their a seminal paper asking the question of whether cannabinoids and targeting the cannabinoid system is actually going to be a beneficial pharmacotherapeutic target. And actually they found that it, certainly in terms of the literature, there isn't enough proof that this is a viable system for us to target. However, there is a huge placebo effect associated with certain medications, and we know that the placebo effect is real. So when we think that we have experienced pain relief and then we're told that it's a placebo, well, that pain relief we experienced was real. So this idea that we might be given a pain medication, which actually the literature goes on to say this isn't providing the pain relief that you think it is, that doesn't matter if we have believed that pain relief to happen. So it's not an alternative to morphine in the acute sense, nor in the chronic sense. However, it has a real effect on the placebo response, which itself is a real analgesic pathway.
Great, thank you. So we have time for one question more. There are so many, like it's great. So we have Alex. So how difficult are the ethics of causing pain in animal models?
Yeah, another brilliant question. And as you would hopefully expect, we have to jump through many, many hoops in order to be allowed to cause pain in animal models. We are very heavily regulated by the Home Office. We all have very strict guidelines regarding our personal and project license with the work that we can do in animals. And at any moment, if we're caught in infringement of what our rules tell us we're allowed to do, we are at risk of losing our license, which of course means we lose our ability to conduct research. So the regulation of animal models of pain is very, very high, exactly as we would expect, and it should be.
Great. Thank you for clarifying that. I think it's a question that many people may have. So how you study pain and do you cause pain in those animals? But yeah. Okay, so great. Thank you, Kirsty. I think that was brilliant. I really enjoyed it. I hope you did too. There's so many questions in the chat. I hope we could answer them all. But yeah, we'll have to move to our second speaker. Thank you, Kirsty. Good evening.
Bye.
Bye. So, Val, do you want to know a fun fact about pain?
Always.
Okay. So, did you know that actually our brain does not feel pain? Because we don't have pain receptors in the brain. So, have you seen those videos in YouTube where neurosurgeons are operating in awake people? And actually, the reason.
Yeah, I have actually seen all those videos. I've seen lots of videos of operations for some strange reason. Yeah, you can see them playing the violin or playing the guitar when they have the top of their heads literally open. It's actually incredible to watch. But yeah, it's really interesting to see how, if pain is something, it's a mechanism that helps us. Why doesn't the brain have that mechanism? It's something that I could have asked Kirsty. I may well be able to later on, but it is something to discuss as well. Because, as she said, it is kind of like, I always felt of it as like a fire alarm. Pain is something that when it goes off, just like a fire alarm, it's really annoying. Obviously it hurts and the alarm makes a sound. But obviously it is really necessary and kind of protective before, any real damage really happens, right?
Yeah, exactly. Can you imagine like a fire alarm that is beeping all the time? Can be like really annoying, or the other way around, that is not working properly and it doesn't alarm when it should.
Yeah, no, exactly. I mean, I can think of at least a couple of sitcoms that have probably like profited from this whole fire alarm malfunction situation, right? But anyway, here to tell us more about what it probably feels like when this system kind of isn't working quite well is our next speaker, of course, Dr. Amanda C. Williams. So hi, Amanda.
Hi.
Hi there. Thank you so much for coming. It's wonderful to have you here. And so Professor Williams is an academic and a clinical psychologist at University College London and at the Pain Management Centre. So she's been an expert in persistent pain for over 25 years. It's very impressive, Amanda. Professor Williams will talk to us about the connection between pain and mental health and its effects in our society. So as before, just pop any questions or comments in the chat as she goes along, and we'll have an opportunity to ask as many of them as we can at the end, okay? So over to you, Amanda.
Thank you very much, and thank you for inviting me, and I'm also delighted to be sharing a platform with Kirsty. So, we've touched on the subjective aspects of pain, and here are some representations of pain. Some are artistic. These are by Deborah Padfield, who has co-produced with patients various images of pain. We have anatomical diagrams, and we have the faces and postures that people use and the definition of pain. And what the definition really says is that only the person with pain can tell us they're in pain. Nobody can either confirm it or deny it by any other method. So, as we know, pain is there to protect us. These are the hands of a child who has what's called congenital insensitivity to pain, so does damage to his hands without realizing, and has lost parts of several digits. So pain grabs our attention, makes us escape, and then in the medium term, it promotes recovery and healing, and it also teaches us to avoid it in future. And below are several animals who, despite losing parts of limbs, and on the right is a dinosaur with a healed fracture, they have survived. So pain intensity doesn't tell us how much damage has happened. It tells us how much danger we're in. And it's aversive, so that it makes us act over anything else that's happening. So it's necessary for survival. But because it's subjective, it's very common that people are skeptical about it. And here are some appalling descriptions of people who had nothing on their x-rays of their backs, but clearly had back pain. So being called immature, shy, mother-fixated, emotionally adolescent male virgins, simple-minded hypochondriacs. It's very cruel, but it's very widespread. This is just blunter than most. And those are social and cultural values. They're not medical, they're not based in psychological theory, but they come over as medical opinion. And they're part of our lay discourse as well about fighting and overcoming pain and being brave or being cowardly. And they also underlie some of the gender and ethnic differences. But actually what's happening is happening in the brain, as Kirsty described. One of the foremost researchers has described the brains of chronic pain patients as very sick, because the changes that happen over the time of chronic pain change the whole processing of pain. It's a recursive situation. So for a long time, people used to give people the same stimulus. This isn't the usual pain stimulus. This is someone having a Botox injection. And, for the same externally given stimulus, some people would say it was pain of 1 out of 10, and some would say it's 9 out of 10. And so it was thought to be just unreliable, and people's reports of how much pain they're in were disregarded. And then more recently, we've been able to image the brain and see what's being activated, which areas, which pathways are being activated. And it turns out that there's actually quite a good relationship between activation in more emotional and threat processing areas and how much pain people say they're in. So when people tell us they're in pain, they're actually telling us quite a lot about what's going on in their brains. Of course, there are multiple influences on pain processing, but the focus is often on the genetics, the chemical, the structural, all of which are terribly important, and on peripheral events, because it's much harder to investigate some of the things that are happening in the brain, people's thoughts, their feelings, their beliefs, the beliefs of those around them. But that's what psychology deals with. So chronic pain has various impacts on people, and these are statements taken from patients. So there's a tendency to focus on threat. So all of us know that our joints click at times, but if you think the click means that bits of bone are chipping off each time, and that eventually your neck is going to collapse, and nobody is taking you seriously, nobody will fix it, then you can see how terrifying that is. And the most sensible thing to do would be to keep absolutely as stiff as possible and move your head as little as possible. So people's behavior around pain is often based on these very worrying beliefs. Pain interferes with daily function. It stops people doing things. It stops them doing things they care about, whether that's playing with their kids or going out and socializing, or being able to go on holiday and risk sleeping in strange beds and doing all sorts of things that one would want to do on holiday, or working or whatever. And therefore people start to lose really important parts of their lives. And again, this is a statement from a patient, but one I heard many times, feeling that having lost work, the patient is then a burden on their family. The family doesn't necessarily say that, but that's how the patient feels. And it often cuts people off from their social relationships. Other people don't know how to behave around someone in pain. They're not very good at accommodating their needs, and they drift apart. So these are the sort of things we focus on in pain treatment. Now, it's not treatment that's directed at reducing the pain. It's aimed at trying to help people live more manageably with the pain and even get back to some of the things that are important to them that they stopped doing. So we try to help people identify those fearful beliefs and put them right where they're inaccurate. Help people evaluate more fairly how much of a risk they're at, what is really threatening, what they do have the capacity to do, and to appreciate the strengths they bring to their situation. We look at how attention and memory really play tricks, particularly for people when they get depressed. The brain is very bad at retrieving good memories and very good at bringing back all sorts of unhappy and shaming and other memories in full technicolor and playing them over and over again. And of course, because of those thoughts and ways of thinking, people are understandably worried, depressed, not necessarily to the level of clinical depression, but depressed and ruminating about their situation, which seems inescapable. And understandably, as I said, people avoid activities that they associate with pain or think will cause damage. They're often very restricted in their movements, and they're often in a difficult situation where being disabled offers them more help than being partially disabled and doing as much as they can for themselves. So there are often some quite perverse incentives around this, though they're overestimated in understanding what chronic pain is about. So what I've described are normal processes. I haven't put this in psychiatric terms. They're not psychiatric disease, they're not illness, and they're certainly not moral failings. They're normal processes. It would be very surprising if someone had chronic pain with all the things associated with it and was perfectly cheerful the whole time about it. So the mainstream treatments for pain, we've heard about some of the analgesics, though many patients find none of them is helpful and some prefer not to carry on using them or not to try. There are various other methods to try to reduce the pain by tackling the cause. But if you're really worried about damage happening to your body all the time and inevitably, then pain relief isn't necessarily the answer. And many people, although they get reasonable pain relief, will actually prefer not to use it because they worry that they will miss danger signs. So we recommend that people get as good relief as they can from whatever means, but then take the pragmatic approach I've described to living with the pain by addressing misunderstandings about pain, understanding things about fostering good health, helping people gradually get back to activities, and physiotherapists and occupational therapists are very helpful in this. And helping people reduce the distress, reduce the anxieties and the depressive thinking, and start to feel they can take risks and try things again. And aiming overall for better quality of life. And the kind on the right are the non-pharmacological treatments. I noticed there was a question about that, and the bigger the bubble, the more studies there are, and the higher up they are in that diagram, the better relief they produce. So things like mindfulness, relaxation, counselling, multidisciplinary rehabilitation provide as much help getting people back to a reasonable life as do opioids and antidepressants, but without the problems of long-term use. Of course, some people get, the best deal from doing both of those, and that's fine. There's absolutely nothing wrong with that. So I've been part of a team that has produced many systematic reviews and meta-analyses of psychological treatments. The most recent was last year with 75 studies in it, many thousand people putting those studies together. And it showed that cognitive behavioral therapy is effective short and long term. It improves pain, disability, and distress by a small amount on average. And other psychological therapies don't yet have that track record, so need further testing. They're promising. And then there are self-help methods, which are much more accessible and more translatable. We're not very good at delivering face-to-face treatment in multiple languages, but they're often not tested for how well they work. And people who are depressed or find it hard to get motivated, find it hard to get started and keep on going. Sometimes they include quite unhelpful content, and they demand quite a lot of the people who do them, but they can be helpful. The benefits are often just short term. It's not clear that they can bring longer term benefits. And we need to pay more attention to the outcomes that are important to patients. Here, the grey lines are how important these outcomes are to patients, and the dark lines are how much they get measured in trials. And as you can see, there isn't much of a match apart from emotional well-being and physical activities. There are many things that are important to patients that we're not routinely either targeting in treatment or measuring as outcomes, and that needs to change. So thank you very much.
Wow, Amanda, that was absolutely amazing. Thank you so much for that. It was really entertaining to hear you speak. And also, I think you kind of really ruined the whole fire alarm analogy for us. But in a really good and educated way, so thank you. I mean, I can't help but draw the similarities with anxiety and the research that I'm in, because obviously it's changing that narrative to like how much danger we perceive we're in, rather than just kind of a fire alarm going off. So thank you for educating us hosts as well. I can see there are many questions in the chat for you. So let's see which ones we can bring in. It's being very difficult to pick. We have one from Catherine Shaw. So Catherine asks, how can we educate the public that pain doesn't make you weak? You don't have to fight through it without treatment, and you don't have to fight through it without treatment. Sorry.
Oh, that's a huge question. It's very difficult to think that education alone is going to change that. It's embedded in our culture thinking like that it's a matter of personal courage if people overcome pain, but we don't know how much their pain is or how difficult it is. I would like to see people with pain assert themselves more. It's often tempting to try to pass as normal and just accept that because people can't see your pain, they're going to take no notice of it. And it's great to see more and more people with pain taking a very active part in debates, in studies, in the whole public face of this. And I think that's, if anything, what will change things.
Absolutely. You're absolutely right. It's being able to bring up those voices that are sometimes forgotten. Brilliant. Do we have any other questions? Yeah, we have one from Ellen Isaac. So, is there a holistic approach for pain relief? Would it behove everyone to stop living in fear, doubt, worry, and anxiety?
Well, we need to fear pain initially to work out what it is and what to do about it. If we didn't fear it, we would never have survived as a species. I mean, fear is what helps us avoid injuring ourselves in the same way. It imprints itself on our memory. But I think we could do with being less fearful about symptoms. On the other hand, of course, some people are not fearful enough. I mean, for all the people who are thought to go to the doctor too often, some others will go too late. or very late in a process, or very late in something which could have been remedied earlier. So I don't think just saying we should be fearless about pain is the answer, but certainly understanding it better helps us use our fear in a way that benefits us and doesn't just paralyze us.
Absolutely. And I think I'm going to sneak in a question of myself, because you've spoken about people not going, perhaps seeking help, and perhaps not going to the doctor at different time points, depending on when they start to feel pain. And I wonder, you've talked about how, because obviously pain is subjective and there's nothing, if you don't have a broken bone or anything kind of seemingly wrong with you, then you're kind of met with disbelief, right, and skepticism. I wonder if people perhaps stop going to the doctor in time because they fear they might be met with this skepticism from doctors and nurses. Is this something that happens?
Definitely. I've heard that from so many patients, that it's just distressing and disappointing and even humiliating going through that process of trying to insist that you're in pain, and the clinician facing you says, yes, but you managed to get here, or you've sat in the waiting room for an hour, so you must be okay. And I mean, I'm afraid to say the benefits assessments do the same. They'll say to people, well, you got up the stairs so you can work. Well, nobody gives you a job walking upstairs once a day. I mean, it's such nonsense. It ties into all these cultural beliefs that are really problematic and quite unkind.
Yeah, it seems like there's a lot of work to do there in the health service as well to tackle that stigma, I imagine. Brilliant. Thank you so much for answering that. I wonder if we have any other questions. Yes, so we have one from General Analgesia Innovation. So they ask, chronic pain patients can wait years for a diagnosis. So endometriosis can be 7 years. Has any work been done to look at mental health of patients with and without a diagnosis?
It's certainly very distressing going around different people and seeking information yourself to try to get a diagnosis. And it often means that it's hard to think of what other approaches one might take at the same time. Unfortunately, once one looks for diagnosis in the hope that, like many diagnoses, it'll come with a cure. But of course, endometriosis and other things don't. And even if surgery resolves the endometriosis in terms of tissue, that doesn't mean the pain necessarily goes away. And what we would like to see is a more holistic approach, really, to managing pain early on. So, of course, trying to get a clear diagnosis to rule out things that can be treated and should be treated, but also to be thinking about how one manages in the interim, because years and years, in those years, people lose a lot waiting for the diagnosis. And then when they get the diagnosis and they're told, well, they've got a chronic pain, or it might have another name, but effectively it's a chronic pain, it's really hard then to start trying to retrieve all the things that have fallen away.
Yeah, absolutely. Thank you for that. We have time for a couple more questions. So let's see if we can have the next question, please. So Jay Mutz asks, is there any research that has examined whether health outcomes are worse in people with chronic pain with comorbid mental disorders due to increased rates of drug misuses, for example, self-medication?
Well, there's certainly a link between having certain mental disorders and being more likely to develop chronic pain, and that's probably because there are common roots. We know if people have a history of depression, they're more likely to get chronic pain. But I don't know that there's anything much that would make the link that you ask about with drug misuse, because people vary a lot on their use of drugs. Sometimes we wish people gave them more of a try. Obviously, the emphasis is always on trying to make make sure that people don't run into problems with them, or if they run into problems, that we help them out of them. But I don't think there's such a clear link. But maybe that'll turn up in the research to come.
Yeah, and I can imagine there might be a difficulty with prescription. So perhaps that issue of prescribing drugs to someone with a history of drug misuse might be problematic as well. Brilliant. Do we have any other questions? So Lucas asks, I hear there are or have been trials with psychedelics as a partial treatment for patients to help with fear, anxiety, depression, and lessen pain. Is there any progress in that area?
I think the progress is extremely slow because it's so hard to get permission to experiment with them. And then the people who come forwards to volunteer to try often aren't people with the disorders that we're interested in whether the psychedelics might be useful to treat. So very, very slow progress. I mean, there is some promise in psychedelics for some kinds of depression, and because there is a link between depression and chronic pain, just speaking at a very broad level, then it's certainly something that should be thought about in relation to chronic pain.
Mm-hmm. Yep, I know of at least a couple of studies going on at King's and also Imperial College, if I'm not mistaken.
Great.
I think we can squeeze in one more question. What do you think, Joana? Just the last one, because there have been so many great ones.
I mean, I really enjoy, so please go.
Brilliant. So we have the last question, which is, so what about nerve pain like sciatica? Where it's not an alarm response, there's no way to change your behavior to alleviate it. I guess that must be where mindfulness or hypnotherapy would be helpful.
Therapists would feel that there are things that you can change posturally and, in terms of strength that are certainly worth trying and help some people to alleviate it. It depends exactly what it is, because sciatica is a very broad label and it isn't always quite what is implied by the label, or it's more complex. It's become more complex. Mindfulness and hypnotherapy, certainly both of them have promise. Really, learning to self-hypnosis, it's no good if you have to keep going to a hypnotist, which is usually private and adds up over the years. And mindfulness seems helpful, but all these things need testing for what they help. And the trouble is that the outcomes tested often aren't very good, and they don't look at whether people get back to doing the things they want to do and enjoy. They just look at whether they generally feel better afterwards, and that isn't quite enough. They need to be tested a bit more rigorously.
Fantastic. Thank you so much for all your questions. And yeah, I mean, it boils down to having the right sort of outcomes, what is important to us. There's no, as we know, and as we've talked about for the entire day, an objective measure of pain, because that's not even the whole point. So if we're not measuring what's really important to us, then we should have a strong rethink about that, shouldn't we? Amazing. Well, that's all we have time for today, Amanda. Thank you so much for your talk and for answering all of our questions.
Thank you.
Bye. Take care. Thanks so much.
So amazing talks, but I mean, I think I enjoyed a lot the discussion, so many questions, and unfortunately we cannot answer them all during this session, but thank you very much for that. I would like to thank our amazing speakers for giving so clear talks and being so kind and answering all the questions that we addressed to them.
Mm-hmm. Yeah, absolutely. I mean, it's been absolutely wonderful. We've clearly realized that it is all in our heads, but obviously our heads are the center of everything, so really listen to them. And thank you absolutely to everyone who's been watching. Thank you for the entire team who's been really, really helpful throughout the entire event. I mean, not just today, bringing it to you, but also behind the scenes for many weeks before.
Yeah, exactly. And also, we would like to mention that the Pint of Science is online tomorrow as well with very interesting events. So please follow them in Pint of Science and follow their Twitter account with the hashtag that you could see here, hashtag Pint21. Also, the event will stay on YouTube. So if you enjoyed it, please share it with friends or family. And as Val mentioned, I would like to thank the team behind the scenes. So thanks to George, thank you Lottie, thank you Fran, thank you Anastasia for making today this event come to life with all the technicalities behind, but also to the rest of the team that has been working really hard. And yeah, of course, our wonderful speakers, Pint of Science, that makes science spread.
But most importantly, thank you all for watching. And with, you know, nothing else to say, have a lovely rest of your week. Take care.
Thank you so much.